All right, let's talk about something that is quite literally a lifesaver, the modern medical ventilator. Today, we're going to break down exactly how these incredible machines take over the most fundamental job there is, breathing, when a person simply can't do it on their own.
I mean, just think about that for a second. It's a terrifying question, right? It's a problem that medical science has been tackling for more than 100 years. When our bodies lose that basic ability to pull air into our lungs, we need help. And for a very long time, the solution looked nothing like what we have today.
And this was it. Meet the iron lung. Now, instead of pushing air into a person, these absolute beasts of a machine did the opposite. They created a vacuum around the patient's entire body, which physically expanded their chest and, well, pulled air into the lungs. It was a genius invention for its time, but you can just look at it. It was also incredibly restrictive. And that gets us right to the heart of the problem with this whole approach. While the iron lung could, force someone to breathe, it was basically a blunt instrument, and it came with some really serious limitations. So here's the real issue. With this negative pressure method, you had zero, and I mean zero, precise control. You couldn't dial in how much air was getting into the lungs or how fast it was going in. And just try to imagine putting a patient with broken ribs inside one of these things. It was just totally impractical. It became obvious that medicine needed a smarter, more delicate way to breathe for a patient. So, if pulling air in was the problem, what was the solution? Well, it was the complete opposite, pushing air in, something we call positive pressure ventilation. And to really get our heads around this, you don't need a medical degree. All you need is a super simple analogy that's going to unlock this whole concept for us. Just picture this in your mind. It's really that simple. Instead of pulling air in from the outside, today's ventilators push air in, just like you're blowing up a balloon. And this shift from pulling to pushing, well, that was the whole game changer. Why? Because it gives you precise control. So let's run with it. The pipe is the patient's airway, and the balloon is the lungs. If we can understand this simple action, we can understand how every modern ventilator works. I mean, really, think about it. Every time you blow up a balloon, you do these four distinct things without even realizing it. You make the decision to start, you push the air with some kind of force, you decide when the balloon is full enough and stop, and then you let the air out. Believe it or not, every single breath from a ventilator follows these exact four steps. Okay, so let's get into the nitty-gritty. We're going to focus on the first half of the breath, the inflation. We'll take those simple steps from our balloon analogy and start translating them into the actual terms that doctors and respiratory therapists use every day. First things first, every breath has to start somewhere, right? That starting gun is called the trigger. It's just the signal that tells the ventilator, okay, go time, deliver a breath. Sometimes it's just a timer, but it can also be the machine sensing the patient trying to take a tiny breath on their own. In our analogy, it's that simple thought. Okay, I'm going to start blowing. All right, so the breath is triggered. It's started. Now what? The ventilator needs a strategy. How is it actually going to push that air into the balloon? I mean, into the lungs? Well, it basically has two main ways it can control that inflation process. So you've got two main philosophies here. On the one hand, there's fixed pressure. Think of it this way. The machine just keeps pushing air in until it hits a specific pressure target inside the lungs, and then it stops. On the other hand, you've got fixed flow. This is all about speed. The machine pushes air in at a perfectly constant, steady rate. Both are just different ways of putting a limit on that inflation. Okay, and this is a really cool little secret about how ventilators work. You're probably sitting there thinking, hang on, what about the volume? Isn't the whole point to get a certain amount of air in? And you're absolutely right. But here's the thing, ventilators don't have a volume knob. They pull a clever trick. They achieve a target volume by controlling the flow for a very specific amount of time. And that's where inspiratory time comes into play. It is exactly what it sounds like. It's the total amount of time the ventilator is actively pushing air into the lungs. You see, a certain flow rate delivered for a certain amount of time equals a specific volume of air. It's as simple as that. So the air is going in, but at some point it has to stop, right? So what tells the ventilator to stop inflating and get ready to let the air out? That switch, that transition from inspiration to expiration, that's called cycling. It's the exact moment in our analogy where you stop blowing. Now, during that whole inflation phase, the machine is working against two forces at once. Part of its pressure is used just to push the air through the pipe. That's what doctors call airway resistance. And the other part of the pressure is used to actually stretch the balloon itself. That's the pressure in the alveoli, the tiny air sacs in the lungs. The absolute maximum pressure needed to do both of those jobs combined, that's what we call the peak inspiratory pressure. All right. The balloon is inflated. The hard part, the active part, is done. Now we can move on to the much easier second half of the breath, just letting the air come back out.
And this is a really important distinction to make. Unlike inflation, where the ventilator was actively pushing, expiration is totally passive. The machine simply opens up a valve, and the natural elasticity of the lungs and the chest wall does all the work, gently pushing the air out. It really is just like letting go of a balloon and letting it empty on its own.
Now, how fast that happens depends on a few things. A narrower pipe or airway is going to slow things down. The pressure that was built up inside the lungs matters too, and so does the stretchiness of the balloon itself. A brand new, stiff balloon empties way differently than an old, soft one. Doctors have a word for that stretchiness. They call it compliance. And of course, you have to give it enough time to empty out. But here's a thought. What if you don't want the balloon to empty all the way? In our lungs, if those tiny little air sacs collapse completely at the end of a breath, they can get damaged, and it takes a lot more work to pop them open again for the next breath. To prevent this, clinicians use an amazing setting called PEEP. The best way to think about it is like gently pinching the neck of the balloon, so a little bit of air always stays inside. This keeps the lungs open and ready to go. Okay, we have covered a lot of ground here, all the way from the trigger that starts the breath to the PEEP that finishes it. So now, let's bring it all home and see how our simple balloon analogy maps directly onto the complex, life-saving reality of mechanical ventilation. This right here, this is our cheat sheet. This connects everything we just talked about. That decision to start blowing, in the hospital, that's the trigger. The strategy for pushing the air in, that's the limit, whether it's by pressure or by flow. That moment you stop inflating, that's cycling. The pipe is the airway resistance, the balloon itself is the alveolar pressure, and not letting it empty completely, yep, that's PEEP. It all fits together, and it's a beautifully logical system. So that's it. That's the mechanics of a single machine-delivered breath. But the real magic, the real art of medicine, isn't in just one breath. It's in managing millions of them. It's in the constant, delicate dance of fine-tuning every single one of these settings, second by second, day after day, to perfectly match a machine to a patient's unique and changing needs. It's an incredible partnership between technology and human biology, all to sustain that simple, vital act of breathing.